latest AI video, but I wish I have the same view from my office.
Okay, okay. Very beautiful. Michael, we will start 5 minutes maybe after 8 p.m. here in Brazil. I thought it's 7 p.m. for you, is
Yeah,
right?
it's 7. Yeah, it's 7 my
Okay,
time.
okay. I will make some announcements before in Portuguese. I know you understand very much
Oh
Portuguese.
yeah, every word. Yeah.
And after that, I will let you know when to start.
Mhm. Can you see my screen sharing already or not?
Yes, 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 I see clearly, and I actually I'm blindfolded to not break my surprise about your wine, my friend.
Oh, okay. Well, now that I specifically put the teaser here, but the story is much more interesting about it. So
Okay, I'm curious.
I'm just well, everyone can read it, but that's not the whole story.
Okay, okay. Thank you so much. Thank you so much for your time. I know how difficult for you to come here and to stay here with us tonight. And
That's fine. My
uh,
pleasure.
it's a big pleasure for us. Eh,
I see also familiar faces. Hi, Andre.
Hi, it's been a while since I saw you the last time.
Yeah, it's been.
Yeah,
You,
thank you so much for joining
you
us.
look older.
Yes, and it's true.
Yeah, well,
I
time is
think
flying.
maybe 7 years, or at least 7 years.
Yeah.
Yeah,
I was
you look
just
the same. I
I,
don't know if it's AI, but you look the same.
no, that's not AI.
Okay.
My voice is a little bit down, but I it's actually I lost my voice when in Florida, and up until now it's still kind of up and down. So, but otherwise, yeah, I mean, other than I have five grandkids, everything is fine. It's the same.
okay, 5 kids, five
Five grandkids.
grandkids, incredible. Okay,
Yeah.
congratulations.
Thank you. That's probably my best achievement. Not really mine, but secondary too.
Yeah, yeah. What city you live?
Toronto.
Oh, Toronto. Good.
Yeah. Yeah, I was just trying to think when the last time I visited Brazil. It's probably about 10 years ago, maybe more.
Really, really? Oh my
Yeah.
gosh.
Yeah.
Oh. Unfortunately, we don't talk before our meeting in Florida, in Tampa, because this year is the year of our Congress, Brazilian Congress, sobre, and unfortunately, it was not possible to invite you
That's fine.
at the
I'm trying
time.
to
I'm
minimize
sorry.
my travel, but yeah, keep in mind. I'm not,
Okay.
uh, I was thinking I'll need to carefully formulate your wishes. When I was 30, I was dreaming of a job of my boss who was like 6 months away. But then I was, a long time for 6 months away. And it was very tough.
Yeah, yeah.
Yeah.
But the next time we will invite you, my friend.
Okay. Well, it's a deal.
Okay.
I mean, like next time I'll be probably in South America. I was invited to Colombia in July, but I'm traveling to Europe the same time.
Okay. Okay.
Yeah.
We'll wait a little bit more time to.
Sure.
Uh,
Everyone, meanwhile, can read about the
yeah.
wine.
Yes. Yes.
And actually, I have the bottle right here.
Great. Oh, great. Great.
No, I mean, I'm not joking. It's like it was a
Yes.
deal. I mean, the same wine, the
Yes.
same year, even
Yes.
same
Yes, I
2022,
know. I know.
2020.
Yes. I'm waiting you here, my friend, with my bottle. Yes.
Okay. Andrew, where's your bottle of wine?
Yes. Show, Andre. Show us.
I don't have the wine because actually I've got a flu.
Oh,
Yeah,
I-
I'm sick.
okay.
That's
I
why you thought I'm older.
sure, but I heard that mulled wine is also good for flu.
Oh yeah? Which one?
Yeah.
Yes. Yes. The anti-inflammatory effect is good. The wine anti-inflammatory is very nice. I recommend you to drink that.
Just don't take expensive wine to heat it. Is it still flu season in Brazil?
Yes, there's a flu shortage in my kids' school.
Oh,
Influenza A.
yeah, well, yeah. I think it was our flu season is over, but it was pretty brutal. I hear you.
Tia, abre o microfone da Cecília, por favor.
Liberado.
Ah, tá bem.
Boa noite.
Boa noite.
Bem-vinda, Cissa. Welcome.
Obrigada. Thank you. Well, I have here sparkling water. So
Oh my
sorry.
God. Oh my God.
It's the champagne of the nature.
Yes. So I will have to learn also about wine.
Yeah, I was told my presentation would not fly without wine, so I said, okay, well, I will try it, do my best.
Não.
Actually, it reminds me one of the meetings in Banff. It was a long time ago. It was a meeting, and the meeting name was Scan and Ski. It was one of the ultrasound meetings. So the morning it was on you hit on slopes, and it was cold because February Banff is very cold. But when you're coming back, you have you change and you go to lecture hall, and on the way you get the beer, including a lecturer and then including the presenter, and then you
Great.
present it with the beer. That was one of the important things.
Important thing.
Yeah, you always need to present with a beer in your hand. That was a great meeting.
Okay. Angel,
Hello, how are
¿cómo
you? ¿Cómo
está?
están?
¿Todo bien, amigo?
Todo bien, todo bien. Listo para la charla.
Gracias por estar con nosotros.
No, thanks to you. I'm very happy. Waiting for the lecture. Very
You
happy.
see, I understand Spanish more than Portuguese. I can tell.
Mhm.
Yes. Okay.
Especially South American Spanish, not Castilian Spanish.
Yeah. I will start the announcements, Gofeld. Then I let you know the time for start, please. Boa noite a todos. Nós estamos começando aqui mais um Pen Wine, um convidado muito especial, Dr. Michael Gofeld, do Canadá. vai falar de uma tecnologia nova para nós aqui, é um trabalho pessoal dele muito importante, que é o HIFU Spine. Vocês vão ver aí grandes avanços aí, eu acredito que vai ser um futuro muito próximo aí para que nós todos possamos usar essa tecnologia. Então, thank you, Gofeld, once more. Quero agradecer lá aos nossos patrocinadores, que é a Genismed e a UOMED. Convidar aí todos os sócios da Sobramid a estarem presentes no nosso Congresso Brasileiro, que vai ser de 26 a 28 de junho. Também convido aos não sócios a tanto se tornarem sócios, como também estarem presentes. É o maior evento de dor do país e da América Latina. São mais de 22 convidados internacionais, os grandes nomes de dor de todo o país e da América Latina e do mundo presentes. Será aí uma oportunidade única, que acontece apenas a cada 2 anos. Então, na verdade, é o nosso grande evento de dor. E hoje nós vamos sortear 2 inscrições para o Congresso Brasileiro. Essa tecnologia que nós vamos ver aqui, o Dr. Gofeld é um dos desenvolvedores, né? O HIFU Spine. E vamos aqui ouvir dele aí diretamente sobre o tema. Gofeld, thank you so much once more to join us in our Pain Wine meeting. Maybe there is a big surprise your wine, but all Brazilian pain doctors I expect to hear about your new technology. I saw it in 2 or 3 months ago in Tampa. I loved, and once more, thank you so much.
Okay, well, thank you for inviting me. Buenas noches.
Sí,
Buenas noches. That's easy for me to.
Sí.
I think I don't know what is more interesting, wine or topic, but I'll start with wine as I was told and was asked. So this wine, everyone can see it in the post and read it, but I'll just explain you why this wine. So I'm a member of the club. It's called Two Sisters Vineyard. So in Canada, as you can imagine, and specifically in Ontario, which is more north, right? To make a good red wine is very, very difficult. White wines are great. Like white wines in Ontario are very good. Champagne type of wine and ice wine, of course, but a red wine is just not enough sun. So this vineyard was established in 2007 by two sisters, Angela and Melissa. But the first wine, it was not until 2010. And on the harvest, they made a little bit celebration. And the celebration was near the 11th post on the vineyard. And everyone who participated in the harvest put their name on this 11th post. And that's how this wine was born, the blend 11th post. And it's used three grapes of the vineyard. That's basically, that is in vineyard Merlot, Cabernet Sauvignon, and Cabernet Franc. And they are all maturated or fermented separately. So that's why this wine is very unique. Now, most of the time in Ontario, to get a good red wine, it needs to be in a barrel for at least 3 years and sometimes 5. So that makes it very expensive also. Any Bordeaux type of very good Bordeaux type of wine will be less expensive in France or California, but it's super expensive in Ontario because it's just too much work to do. So that's my story about this wine. And you can read about tasting notes. So should I open it?
Great, great. Yes, please.
Okay. Now, anyone who is coming to visit Ontario and Niagara region is more than welcome to visit this winery and enjoy good wine. There is also almost Michelin star restaurant there, which is also called 11 Post.
Great.
You need to reserve the place, but if you let me know when you're coming, I will make a call.
Okay.
Cheers,
Okay.
everyone.
Cheers, cheers.
Yeah, good wine. Okay, so shall we go to presentation?
Okay. Yes, please, Gofeld.
Okay, so let me know if you don't see anything. So we'll talk about HIFU. HIFU is a high intensity focused ultrasound, and I'll talk specifically about what we are where we are involved as pain physicians, and not much clinical applications now except spine. So my disclosure, I'm a senior clinical advisor of the startup. It's still startup, Fast Mobile. And I did funded research of this company. Otherwise, no disclosure. Now, so when we talk about high intensity focused ultrasound, doesn't look like it's playing.
Gofeld.
Now it's playing. So it's basically, think about a magnifying glass. Any energy when it's focused comes from the magnifier, being light or ultrasound or magnetic or anything else. And it's focused to a specific region, should create enough energy to at least to have a thermic effect. That's basically how the HIFU works. The history is started way back. So we attribute HIFU to brothers Fry. That's William Fry. They were founder of bioacoustic labs in the University of Illinois, and they created this first ULTRAS HIFU device like this with 4 separate beams, and they dreamt to introduce it to a neurosurgery practice. Now, the really first HIFU was actually was born in 1939, but it was really developmental process in the lab. This was the first device that was actually used on patients. But you can imagine, in 1960s, imaging technology was not there. So no MRI, no even CAT scan that could be used simultaneously. So it was very cumbersome, and it didn't go too far. And it didn't go too far until pretty much 1980s, when the first company that was called Insightec came up with a technology that incorporated HIFU in the MRI scanner. So this slide shows you Insightec device, and since then it's exploded. There was a fast foundation that I don't want to spend time, but there are hundreds or maybe thousands of research projects going worldwide, animal and humans, exploring out high intensity focused ultrasound in many aspects, including oncology, including musculoskeletal, including neurological disease, and etc., movement disorder. Now it is mostly used either with a MR scanner or very high definition ultrasound, very robust ultrasound. For example, for breast or for prostate, now there are devices that use ultrasound imaging. Now, there is also not quite something new in related to spine HIFU, and this was one of the studies that was done on swine model from Cornell University, and you can see probably here like familiar names. Amit Gulati was a senior author, and they conducted this on live pigs using the far field and near field. Now, I need to say that HIFU with under MR guided, they must use two fields, like two conuses, if you can see here, the two transducers, that's far field and near field. Now, you can see here, it isn't even the far field passes through spinal cord or spinal nerve roots, and there was no damage registered in histology, because as much as it sounds dangerous, until it's very focused, there is really no temperature increase in the field. They also conducted the next study, and the next study was again swine model, same group for sacroiliac joint, and also the same was result was the same contiguous lesions in the right and left sacroiliac joint with no damage of underlying structures, and there was concluded that it works. I can also show you that was never done on animal or humans, but it was this a simulation that this group from the Oxford, UK, they created the model using also two beams imaging of HIFU to create an intravertebral disc lesion. It's just imagine like any intradiscal lesions, and I believe the first time I was in Brazil, I actually was presenting bioacuplasty in São Paulo, and now it's, at least theoretically, it is possible to do the same lesion non-invasively. How nice it would be, right? But I think it's not far away from clinical work. Now, let's talk about the challenges. So all challenges of HIFU, all challenges of HIFU are presented in this picture. Like if you can imagine that, I don't know how many of you have available MRI image on everyday basis. I doubt it's really handy. Now there's Insight Tech cost about $1 million+. It's very handy to do brain lesions for Parkinson's or essential tremor, but in a normal life of the pain clinic is probably like mission impossible 7 or 8. There's patient will need to be in a scanner even for simple facet ablations between 2 and 3 hours with all planning. Most of the time, patient need to be sedated because it's very movement sensitive treatment. So you can imagine like it will not be a real deal in our reality. But what if the machine is miniaturized? What if the imaging instead of MRI would be a familiar fluoroscopy? What if the operation is intuitive? And what if efficacy is the same or superior to radiofrequency? And then my rest of my presentation will actually address all this what if. Before we do it, we need to talk about a little bit about HIFU physics. So most of the time we're talking about two bio effects. One is mechanical, so beam that is projected with certain frequencies will result in in friction and results in mechanical disruption of the tissue, which we call histotrypsy, which is, by the way, what we do for kidney stones. It requires very robust machine, and the transducer is fairly large. Now, the second effect is thermic effect, which again, because the energy is concentrated, it will create, from the same friction, it will create molecular friction, with elevation of energy, and it may be from mild hyperthermia to actual thermal coagulation of 100 degrees. Now, the thermal effect is much more predictable. At the end, at the end of my talk, I will tell you about a couple of more effects, but let's just stay with the thermal effect. Now there's not also quite simple to create thermal effect without bifocal beam, and that's why we need to capitalize on two things. First, a bone. So when the high intensity focused ultrasound meets a bone, because the bone is absorbing energy much higher in a higher rate than surrounding tissue, it will create a blast on the surface of the bone. The second is capitalizing on incoherent mode, which I explain in the next slide. So what is incoherent mode? Incoherent mode basically it's, if you think about the emitter, this kind of the emitter of HIFU, it's several rings there, multiple rings, and every rings will emit same frequency or same energy, but it can be emitted in the same time, or it can be emitted in a different times. And if it's emitted in a different times, those rings or this signals will confuse each other, and they will not create a lesion. They will create a zone that we call therapeutic zone, about 5 centimeters. In this 5 centimeter zone, the lesion will be created only if the beam meets a bone tissue. And by meeting bone tissue, it will be absorbed and creating a lesion. So that's why it gives us an opportunity to either to put the actual the center of the lesion a bit above the bone or beyond the bone. It will create the lesion regardless, as long the focal zone is within 5 centimeters. Now, what if there's no bone? So as you can see here, there will be no damage because the beam will meet, cross, and dissipate. That's why in an incoherent mode, there will be no thermal lesion of the soft tissue. Again, it's a good, at the same time, it's not really good because incoherent mode cannot be used in soft tissue. But using incoherent mode gives us opportunity to miniaturize device. So instead of 20 centimeter of ring, we can miniaturize it to about 10 centimeter, which makes it more compatible with daily practice. So this slide also shows you basically distance in a geometric center and the simulation with the tissue. So in this graph shows you the peak of coherent versus incoherent. So the pressure, which is pressure gain, which may be translated to thermal effect, is way smaller than in coherent versus coherent. Now, there's also simulation. What I'm showing now is one of our publications shows the simulation on a bone, which is based pretty much the site of the medial branch, with 1,000 joules and 2,000 joules. And on the 1,000 joules, you can see the absorption of the heat by bone tissue, and also accumulation of the heat lesion on the surface. With the 2,000 joules, it's even more pronounced, with more absorption by bone and more lesion on the surface. I can also tell you, if you apply enough energy, like with the 10,000 joules, it will be basically creating a hole in the bone, but that's not our goal. So this is a HIFU geometry. It's, you're probably not familiar with chocolate in the United States, and it's not really tasty, but this is a Hershey chocolate factory. So the Hershey Kisses, if you ever tasted it, I mean, that's not my favorite. My favorite is the Belgium chocolate. Actually, Dubai chocolate is very good, but this is not my favorite chocolate, but the size and the shape of the lesion is fairly similar to Hershey Kisses. So white base and a thin proximal part. That's why it kind of spread on the surface of the bone. Let's talk about HIFU anatomy. This is equipment. So we start from the cradle. That's kind of what we use to hold and navigate. You need to use an acoustic gel because ultrasound, as you can imagine, will not propagate through air. This is the device, and you have two cameras, side camera and the front camera, and this to make an integration between a crosstalk between optical part and fluoroscopy part. So this kind of ring here, you can see physical ring, metallic ring, and also on the other side there's metallic ring. And if you put it on in the field, so then these rings need to be aligned, and once they're green, you know that you're in the center of the image. And then we need to do it, of course, lateral view, because as I said, we're limited to a therapeutic zone of 5 centimeters. Whatever is located within these two green lines, the lesion will be created on the surface of the bone. Whatever is deeper this therapeutic zone, almost superficial, which is about 2 centimeters, the lesion will not be created. So that's one of the limitations of the current technology, that the best lesions happen in an average of 7.5 centimeter depth. So you can imagine of any patients with a depth to the point somewhere between 4 centimeter to 9 centimeter. That will be the ideal. So I cannot really I can't remember the size of the patients in Brazil. Some of them are probably more than that, some of them probably less. But as I said to my friend Tim Deere, it will not work in West Virginia because most of your patients BMI 40 plus. Now, I can also tell you the company now is working to produce the next transducer that will capture up to 15 centimeter depth. So then we'll go to tissue experiments. So tissue experiments was, what is good in HIFU lesion is exponential lesion. It will not be stopped by charcoaling like HIFU, like radio frequency lesion. And it's more or less like a cooled radio frequency. The more you apply energy, the lesion will grow. And the lesion in the time of about 50 seconds will be fairly similar in the ideal world of the cooled radio frequency of about 1 centimeter, but not a round shape, but this kind of conical shape as I showed you before. So then there was step of animal experiments, because obviously when you do a process of developing new technology, you need to conduct animal studies. So that's one of the studies on pigs. I showed you a device that was fairly advanced. Now this device, what I show you here, is a simple metal ring with no optical integration at all. It's one of the first primitive devices that we used. This is our first team with two inventors of this technology, Dr. Hananel and Ron Aginsky. So they both from Insight Tech, and they created this device. So this is one of the first devices you can see here. So that's one of our first, not first, but one of the studies we published, tolerability and feasibility of the HIFU on preclinical models. So we did it on pigs. We did it on right-sided medial branches, and you know, at the end, unfortunately, was sacrificed, and the tissue was excised, evaluated by CAT scan, and also micro and micro pathology. So first of all, there's good news that there was no significant adverse effects. The pigs were happy after they woke up. They ate, they played, and was really no any problems. And the most important, that all targets were successfully ablated. How did we confirm that they were ablated? I will get to in a second slide, but that was the second study that we did direct comparison of HIFU and radiofrequency. So one side was radiofrequency, the standard 18 gauge cannula. It was double radiofrequency, and another side was HIFU. Now that was designed, that was mandated by FDA because they wanted direct comparison with existing technology, which makes perfect sense. Now, also I will show you how it was done in technically with you know, cross-placed on the presumably medial branch side, rinse, overlaid, checked on the lateral view, and creating the lesion. Now this is more interesting. So this is a macro pathology of the lesions. So this is, as you can see, this muscle that was intact. This is a RFA. This is a HIFU with 1,000 joules. This is a HIFU with 2,000 joules, including the bone reaction. So it was a time that we tested the feasibility and tolerability of the dose. Now, most important is what we found on micro. So you remember the radiofrequency lesion is growing off the bone, and there is some part next to the bone may not be affected. So I'm not telling you that it was all the time, but if you look at this image, that's the lesion of radiofrequency, and the target nerve is intact. It was not ablated. On the contrary, because HIFU is growing immediately from the periosteum, this lesion includes the bone. Now, what was the percentage of success? You can see here the percentage of ablated nerves with focused ultrasound was 71, 86, and 96% for 1,000, 1,500, and 2,000 joules respectively, whereas the ablation was only seen on 50% with radiofrequency. Now, obvious questions, like we use radiofrequency many years. All of us, we were taught to use radiofrequency. I think I've been using radiofrequencies since my late residency in 1999. So what's the point with radiofrequency? Why all of a sudden we're discovering the radiofrequency is not ideal? Let me get to it in a few slides. Oh, actually right now. So we need to remember that there is a physics. There are physics that many doctors, myself included, were totally ignorant. The picture on the right is actual oscillometry of radiofrequency. So when we see a nice line of the radiofrequency going to 80 or 90 degrees, it does not necessarily mean that this is actually happening in the tissue. In the tissue, as the vector goes up and down with oscillation of the temperature and power all the time. Radiofrequency is heavily influenced by multiple tissue factors, such as blood flow, impedance, location of the grounding pad as close as possible, metal implants, and some other prostheses. Now, we're not familiar with the literature, but if we would read cardiology literature, there's abundance of evidence that radiofrequency does not work on epicardium. So in cardiology, radiofrequency is used for endocardial lesions, but not epicardial. Why? Because it's a FET. And two main local variables may interfere with radio frequency, which is bone and fat. Now, bone, surprisingly, that was Mehul decided, published in like 3 years ago, when the matter of his publication was actually initially to confirm that with cooled radio frequency is superior to conventional radio frequency, but he had to conclude that when the cannula is placed very close to the bone, it influences on negative way and causing non-spherical and complete lesion. And it's not secret that many patients with low back pain, probably most of them, if they are older than 50 and not really functional, they have a lot of fat in the multifidus muscle. And all this story about or history or notion, what is creating what? So first lesion, we do radiofrequency, it creates multifidus degeneration. Or on the contrary, patient with a multifidus degeneration, they are actually a patient that we need to treat because those are patients with arthritis. It's a topic of a different lecture, but let's just take it for granted. Radiofrequency does not work well in fat. And MRI actually showed that. That's one of the studies that we did. Again, not what I was dreaming to do the study, but it was a request of FDA because they wanted imaging confirmation. They said, okay, well, can you confirm that radio frequency works in a certain way in the tissue? And I was thinking it's very simple to confirm, but I did not find any studies because all what we know about radio frequency is how it works in egg white or chicken breast or some gel. There were no studies available whatsoever to confirm how radio frequency works in the human tissue. Now, I don't know why it was overlooked. I'm just telling you that was the situation. Now, on the contrary, there are plenty of studies that radio frequency in the liver, radio frequency in kidney, radio frequency and some other stuff that radiology confirmed, but we didn't do it. Now, and then we did a study on 10 patients. We did patients after routine radio frequency, either with conventional radio frequency or tined radio frequency with deployment of the tines, it's trident, and we send them to MRI. And I can tell you, to my astonishment, I was flabbergasted because in this study, we saw only 20% ablation. And edema that you can say, well, it was some damage, was 44%. So it's very close to what we found on pig study, even though in pigs, there was no multifidus degeneration whatsoever. But we discovered the radio frequency does not work precisely to ablate the tissue, at least in 50% or more. And the degree of multifidus fatty infiltration was negatively correlated with MRI findings. So patients, again, that I told you one slide before, patients with more multifidus fat responded very poorly to radio frequency. Imaging, I'm not talking about clinical effect. It's a different story. But imaging was very disappointing. By the way, this one is just by incident. We captured the track of the cannula, and I just thought it's fun. It will be fun to place it in the presentation. That was not all the time, but incidentally, the slides captured exactly where the cannula was placed. So that's how it works now. We take a fluoroscopy, any fluoroscopy. We placed the board that integrates optic with fluoroscopy. Now, of course, then we need to place the patient and take one picture. So what is there? So this is the machine with a computer screen. Then we place the gel, and then we place the cradle. And now we are playing kind of game to overlay two rings. And when the ring is overlaid, two rings, then we confirm it on the lateral view that is in the area of therapeutic zone. Press the button and the lesion is created. Now, you can ask, okay, what about stimulation? There is really no stimulation. Many people now actually abandon stimulation radio frequency as well. But what we do have, we have a test. And the test is conducted with 300 joules for 20 seconds. So it does not create motor stimulation, but just in case something happens and it shoots to the exiting nerve root, patients will feel it. They will feel sort of irritation of the exiting nerve root and will complain. And then we can reposition the device. So that's kind of the test. Once it's done, click the button, 50 seconds, and now we use the energy up to 1,000 joules, or on the more higher BMI patients, 1,500 joules. It creates pretty much ablative lesion of about 100 degrees at the spot. So what evidence do we have? So this one, the first study, it was started by Jordi Perez, who was that time in McGill. Now he's in University of Barcelona. And I was invited with our group to join it. And that was 10-patient study. And a 10-patient study basically was NRS was 6.2, and 6 months it was 3.4, and even after 1 year it was 4. Now I can tell you this study was small. We still didn't know a lot how to do it and what to do and what not to do. But this study was quoted in 2022 in International Pain and Spine Society meeting as one of the best publication in the year, which I was absolutely unaware. We were there in Vancouver, and they presented the study with good criticism, which actually helped us to plan the next study. And the next study was a pivotal study, was done only in Toronto, University of Toronto, in our clinic. Was the same inclusion-exclusion criteria, which basically, same as inclusion-exclusion criteria that you would take it for radio frequency. It was 30 patients. It was upgraded HIFU system, already with optical integration and augmented reality. And we used a revised anatomical target that I will tell you in a moment. And we also had additional secondary outcome, which was MRI. And the patients underwent MRI within 1 to 5 days. So what is revised anatomy? Our group, John Tranis and Ann Augur, they worked many years very hard to create sort of mapping of the nerves, including medial branches. So they proposed that the distal branch of the medial branch, distal part of the medial branch, is preferred target. Why? Because motor branch is already left, and it's far away from the lateral branch and intermediate branch. So technically, if we could create a lesion here, we'll avoid denervation of multifidus muscle. We'll also avoid unwanted ablation of lateral or intermediate branch. And if you think about our favorite Scotty dog, it will be on the left side 7 degrees, 7 o'clock, and the right side is 5 o'clock, contrary to what we usually do radio frequency. And it will be pretty close or even at the mammal accessory ligament. Now, we always think about mammal accessory ligament as a 4, but in terms of radio frequency, maybe because it shelters. In terms of HIFU, it doesn't really matter because it beams through and actually even creates some sandwich effect, like panini. Basically, the nerve will be ablated between the ligament. And this is the result of our pivotal study. As you can see here, results were even better. At the six months, from 7.2, the pain reduction was 2.9. And again, actually, I forgot to tell you, in 3 months, we saw a spike of pain, not severe, but still spike of pain for unknown reason. We speculated a bit. Why? Maybe because patients were more active, maybe they stopped medications, but we cannot really explain why 3 months was some spike. And because we use ODI, which I advise you never use ODI in your research, because ODI is not meant to convey or to produce any difference on the patient that can walk in your room and hop on the table. So unfortunately, we used ODI and not Rowland Morris, and ODI did decrease by 10, but clinically, minimal clinical significant difference for ODI is 12, so we did not reach it. But nevertheless, the result was fairly significant, and based on the result of the study, European Union, the device passed through EU and also passed Health Canada, and now it started to be used clinically in Europe and Spain, in Italy, and in Canada, in Toronto. So we're just in the beginning. Now, what was really interesting is MRI results. So if you think about tissue edema that manifested by T2 signal, it was detected in almost 70% of cases. Now, ablation-induced necrosis was in 55% of cases, still much better than radiofrequency. Now, if the more you see edema, the more you see ablation, the success rate was higher, clinical success. 7 out of 12 patients that had ablation in more than 50% of target locations, the responder rate of these patients was 86%. So based on only on this MRI results, I can think of the obvious conclusion that actual tissue ablation does matter. And the whole notion about radiofrequency produces also electromagnetic effect, and it is disconnected from thermic effect, maybe. But the more reliable ablation, the better results. Now, this study that is finished, as a matter of fact, today I received a draft of the publication. It was still not published, so I'll just show you a little bit what I can. The group it was done in multi-center study in the United States. What was interesting, so it was 90 patients, right? 80 randomized patients and 10 roll-in patients. Basically, roll-in patients, the patients who knew that they having HIFU. So those patients were included in the safety analysis, but not in the results. And there was 12 research sites, a mix of academic centers and non-academic centers. What was the most important, that crossover that happened between 1 and 3 months was also blind. What that means? Usually we do crossover study, patients who are the sham group, they don't know what the sham group, but if they ask to switch, they're switching and get the procedure done. And the patients who are in the active group, they never go to sham. Here it was actually blind. So patients were able to ask, either group, to ask to switch. So in the patients in the placebo group switch to active, and patients active switch to placebo. Except 26 patients asked to switch from sham, and only 6 switched to placebo. All 6 failed anyway. In 26, they continued the same path of patients who were expected to get better. So that was interesting. So just a little bit results. Now, the study was planned on 2 point of pain reduction with a minimal of inclusion of pain of 6. So that reached the point. Now, this also was 33% difference with 95% confidence interval with odds ratio of 4.3, which basically means the effect size of this intervention was huge and unparalleled to any radiofrequency study that you ever read. So what that means in the real world, it is 4.3 patients would respond versus 1 who would not respond, which is, again, it's basically theoretical consideration, but it's very interesting because its study was powered for both statistical significance and clinical relevance. Now, we also discovered that more level treated got better results, and patients who are started with a high level of pain, 8 to 10, they were the poorest responders, which, again, not surprisingly, patients who complain 10 out of 10 pain all the time, they probably should not be even included into study or should not be even treated. Was also interesting that positive response rate of subject with BMI more than 30 was fairly comparable with normal BMI, which was quite pleasant finding, and it gives the opportunity to treat patients with a higher BMI with this method. We all struggle with the radio frequency or more, higher BMI, but this has probably success or will be more successful with a BMI or higher BMI. So what's the future development, as I told you? The future development, first of all, is ultrasound guided system. What's this called? Neuralizer XR. The next will be Neuralizer US ultrasound. And we just finished the animal study with ultrasound system. Looks very reliable. It works even more intuitive than X-ray guided system because it just integrates everything in one picture. And also the system was the ultrasound guided system. It can work in both coherent mode and incoherent mode. It basically gives an opportunity to do ablation of the soft tissue. It also opens an application of neuromodulation, because based on an ultrasound energy that does not reach ablation temperature, you can either block the nerve or make nerve more or stimulate the nerve. But again, if you invite me one more time, I can expand on neuromodulation as a high intensity focused ultrasound, and it's actually quite booming field. Oncology, apparently we can also do bone metastasis, maybe not as reliable as MR guided system, but it actually works not bad in, for example, ribs. Ribs, it works fabulously well. This, what you can see here is this experiment with the ultrasound system and the MRI of the pig. After, it's a knee, actually, it's a knee. And we are preparing now for the study of knee denervation using ultrasound guided system. So that's pretty much what I can tell you. It's this is our first system. We are first world, first certified clinical site. It happened in January. That's why you can see all white. This is my assistant, and this is my partner Kevin, and Arik you already saw, and Dawn, she's in regulatory affairs to push it through regulatory. So conclusion you can read yourself. It looks very promising, and I'm very excited to be able to contribute to development, and now being the first happy user, including my patients, happy receivers of this treatment. And this is my acknowledgement of, it's not, you can see not all people who are involved, but some of people who are involved, including LBP3 study with 12 sites. And again, thank you very much for inviting me and having the opportunity to present our work and our experience.
Gofeld, congratulations.
Thank you.
It is really good to hear about that. And I would like to know, in in Tampa, you showed one model station, the use of that technology with ultrasound. Probably you use more in your office with that or not, and I want to what's your opinion if you compare with fluoroscopy?
So what you saw in Florida, this was a research system. It's not commercially available. The idea is to fit any probe commercially available of ultrasound system into the cradle. Well, maybe it will not fit every probe, but it looks like we use now G probe and it fits well. Now, I think it will be a somewhat different applications or different targets. My preference, of course, and I think most of the physicians, the preference will be ultrasound guided system, except what if you cannot really see the target? And then maybe fluoroscopy guided system is better. Now, you also need to understand that we are talking, in Canada, it doesn't matter what kind of imaging modality doctors use. I believe in Brazil, it also doesn't matter what kind of imaging modality doctors use, but it does matter in the United States. In the United States, doctors must use fluoroscopy for spine procedures. That's why the fluoroscopy will be, at least in the foreseeable future, the standard of care as an image guidance. We'll see as the time gone by, the system will be evolving and will be more and more new applications. I hope ultrasound will be taking more and more role in our life and our clinical work, but I still don't know. So answering the question, I think there's a place for both X-ray guided system and ultrasound guided system.
Okay, thank you. Andrea.
Thank you so much and congratulations, Michael. One point that I found particularly fascinating is how the lesion is created based on the interaction with the bony surface. This is very interesting, of course, for medial branch. I was also wondering about the potential application for sacrolateral branches. This would be very promising if it were not the limitation of the 7 centimeter depth constraint, if I understood it correct. I would like to ask you if for more superficial targets like lateral sacral branches, there's any possibility or even a conceptual exploration of creating some kind of denser gel bridge, perhaps something that can facilitate energy coupling and allow the ultrasound to reach the focus more superficial.
Okay, Andre, I need to drink for this question.
Me too.
I have a tea. I have a tea.
I can tell you why, because University of West Virginia, University of UVA, University of Virginia, they finished the study. They already finished the study on the sacrolateral branches.
Okay.
The distance can be manipulated by gel. So we have now 2 sizes of gel, thin gel and thick gel. So if you put a thick gel, that's basically, you can do the same up to, well, 2 centimeter, but even 1.5 centimeter, it'd still be fine. So they finished the study. They are going to publish. There's also a study that was, I think 8 patients, pilot study was done in Israel, and they also demonstrated it's pretty, reliable and efficient. And I can tell you, if there was a company representative, the company representative would not tell you, but I'm not a company representative. I'm using already now for the sacral lateral branches. It takes me, listen carefully, between 10 to 13 minutes for the bilateral sacral ablation,
Wow.
which is
Wow.
unheard of when you compare it with
Yeah.
frequency.
Yeah.
And it's
Yeah.
very easy because with sacral branches, there is really no any movement. So we can basically take one image and then you drag the cradle along the sacral lateral crest and you create lesions 1, 2, 3, 4, whatever. So it's very easy.
But
I believe
like
go ahead.
Oh, sorry. You can go further.
No, I believe with ultrasound guided system, it will be even easier because it creates the chart of the landscape. So it's it hits where it hits. There's the risk, both the risk of medial branch neurotomy and sacral is to get away from the sacral crest. That's the main challenge, because if you're in the end of the beam brushes the sacral crest, those patients stay with residual pain for about a couple of weeks, and so not pleasant. But so we already started kind of more than contralateral a little bit, and it solved the problem. I can see here the question about how affordable is HIFU compared to radio frequency. I'm not selling anything, but I can tell you it's more or less comparable with a high-end radio frequency machine like Stryker, for example. So it's more, it's very comparable. The cost per case will be lower because, considering you don't need, you don't have any local anesthetics, you don't have disposables other than gel, you don't need to prepare, don't even need to wear a mask, which is kind of nice. You don't need to be sterile. I believe, in some clinics that I visited, again, we have X-ray technician all the time, but I visited the clinics where the doctor was doing procedures alone. So that's perfect because you can operate without being sterile the serum, and you can also operate the machine. So whoever would like to save on human resources, that's kind of the perfect technology to save. So I'm not trying to persuade that it's dirt cheap. It's not, but we do not see any differences between currently what we use in buying gel versus radio frequency equipment. But it's really simplified the process and the flow.
Probably.
The first doctor who would like to buy it in Brazil, they will probably get into discussion with the company, but not with me.
Okay, Angel.
Hello, congratulations again for the great lecture. I have a question. Once the procedure is completed, how long is the patient on their monitor when you finish after they get discharged?
Great question. I need to drink again.
Cheers.
So remember, typical patient after radio frequency, whether you did with sedation or without sedation, they have quite significant pain most of the time. And patients, some lucky patients, they have pain for a couple of days. Unlucky patients, they have pain up to 3 to 4 weeks. Would you agree? Yeah.
Yeah.
And before I get to your question, so we were thinking all the time that why patients after radio frequency have a significant post-procedure pain. And we were attributing this to a lesion itself. Now, when we did MRI on these patients after radio frequency, we discovered a few things that was quite shocking, because apparently many patients had hematomas inside of the spinal muscles. And now I believe the pain after radiofrequency is not necessarily related to a lesion, but amount of trauma that we created with passing cannula. And cannula was 18-gauge cannula. It's pretty good harpoon. So more time we're trying to pass it, the more chance that you create trauma of the muscle. With a HIFU, 90% of the patient. Now, I need to tell, first of all, it's not pain-free procedure. It's not. It's really, the pain level is fairly comparable with radio frequencies, about 5 on a scale of 0 to 10 during the procedure. Some patients 0, some patients 10. Now, there's how to make them comfortable, it's a different story because we now give premedication. We don't use IV sedatives, but I can really see some use of IV sedatives. And then sometimes you need to say, hey, you know what, it's non-invasive, but I really need to inject it first because the patient cannot tolerate it. But most of the patients tolerate it just fine. Now, the interesting part that most of the patient pain, procedural pain, is completely subsided within 15 minutes after procedure is done. And then most of the patient who responders know it after 1 hour. So after 1 hour, patients already know that the pain of the back pain is significantly reduced or eliminated. The longest period of patients who were responders was about 2 days. After 2 days, we already knew. So technically, after 1 week, you would know, and the patient would know for sure whether they're responders or non-responders. And the non-responders is everything probably to do with patient selection, not necessarily with a technique.
Thank you, Professor. Thank you.
Cissa.
Thank you, Professor. Well, just a few questions about bleeding, antithrombotics and anticoagulants, if you're going to do the same preparation, and the fragile patients.
Okay, what do you mean by fragile patients?
Those that when sometimes it's so hard to get prepared for all the procedures that we don't want to do it.
Mm-hmm.
So if it would be an option?
Well, I'm not sure, but I can tell you what is not a problem. So
Okay.
coagulation is not a problem because it's non-invasive.
Yes.
Patients with implanted defibrillators, not a problem because there is no interference with defibrillator. Patients with implanted spinal cord stimulator or any other implants, not a problem because it does not interfere. Moreover, patients with hardware is not a problem as long as the hardware rods are not on the way of the beam. So if you can get it below the pedicle, basically it solved the problem. It's not a contraindication. What I'm not sure about fragile patients. If you think about fragile patient, very skinny patient, yes, it will be contraindicated because you just don't have enough space there. What I can also tell you, and we excluded patients with severe scoliosis or kyphoscoliosis from study. And clinically, I started to include them. The results are not good. I don't know why results are not good. Maybe because of actual, the general condition, because there was degenerative scoliosis. There are plenty of other pain generators, but even technically to place the cradle reliably on the skin with a twisted spine is very difficult and many times impossible. So that's what I found. The most significant. We don't have in my practice severely obese patients. So we judge now if we do medial branch block, we're using standard 3.5-inch spinal needle, and this needle is not kind of going completely to the hub, this is a patient that is fine to do HIFU. Where I need to use 15 centimeter needle, those patients not for HIFU.
No fun.
Right? If a patient is very, very skinny, it's not. But very skinny meaning, I hardly remember patients with a less than 2 centimeter distance to medial branch. Some of them, but we had on the study was 2 patients who were excluded, 1. So those basically considerations. But I said, well, I will probably not, I will exclude patients. I will not take patients with a severe kyphoscoliosis because it's very difficult and the results are not good.
Thank you.
Gofeld, I know you talk about spine, but probably you have been using sensitive branch for joints like knee, hip, and shoulder. Could you talk about this? Do you have some perspective or results?
No, I've not done it because again, I just told you guys that we're submitting, probably next week we'll submit study knee study for approval. There are 2 studies from Japan. I don't know if you're familiar with those studies, but two studies from Japan. They used HIFU MR guided. Now they did not target genicular nerves. They target actual bone and the periosteum in the epiphyseal part of the femur and the tibia, and the results were very good, was very reliable, which brings it to the point that we are in 2003, was my privilege to publish work in pain with David Neef and Marshall DeVore, and this was published in the with the title of cause of the bone pain, lessons from vertebroplasty, and we stipulated this work that bone is highly innervated inside. We are sort of ignoring it. And there is a role of extrinsic innervation that we are, for example, for the knee, we call genicular nerve and some other nerves, but there is also a role in intrinsic innervation coming from the bone marrow and cancellous bone. And those 2 studies in Japan, they focused exactly there. So I told us it's not possible with a normal energy load to elevate the temperature inside of the bone to boiling, and we don't need it. What we need is to elevate this temperature to just 45 degrees to kill or deactivate nociceptors. And this one basically will be our goal with the study, to focus not necessarily on specific nerves, but focused on this proximal capsule where all nerves come in and underlying bone. So again, we will start the study soon. Hopefully, again, maybe it will be a topic of presentation in Brazil, because I hope it will work. Sorry, but I don't know. Same with other joints. We already know this, the anatomical targets for the hip, for shoulder, wrist, ankle probably. I don't know what to tell you, but it will be probably much easily to be achieved with HIFU than with needles. No matter what needles, radiofrequency or cryoablation, because it looks, to me, it looks much more convenient. Let alone patients would appreciate it as well, because I don't know how about Brazil, but in Canada, if you ask patients what would you like to have, needles, no needles, the answer is pretty obvious.
course. Yeah. Okay. Friends, some questions? Okay. Gofeld, thank you so much once more. It was a big pleasure. And see you next time. For sure, you waiting you to tell about the neuromodulation with the HIFU.
Absolutely. That's my topic. This one,
Yes.
I started this, when I was in the University of Washington. I was a part of biophysics lab, and we did that time we did high intensity focused ultrasound experiments on rats. And I was thinking, okay, it's in my past, and now it came back, and so now I have much more knowledge how to implement it in neuromodulation, and I hope it will be the next step after we're finished with all ablation.
Okay, that would be nice. Thank you so much.
Okay, cheers again, and was nice to see you all, and hopefully to see you again in some meetings here and there.
Okay, sure.
Cheers.
Cheers.
Nice to see
Cheers.
you. Cheers. Good night.
Good night.
Good night.